It's a pleasure to be back with you again. This is Matt Moore from Columbia University. We're going to do some quick tips on amyloid-specific therapy for patients with cardiac amyloidosis. As a highlight, you should know that for AL amyloid, there are many highly effective antiplasma cell therapies, but only one, daratumumab, which is a monoclonal antibody against CD38, has been approved by the FDA specifically for AL amyloid. Many of the therapies that we utilize for AL amyloid are borrowed, if you will, from the myeloma space. And the role of stem cell transplant in patients with AL amyloid is evolving as more highly effective antiplasma cell therapies are being developed. For transthyretin amyloidosis, pharmacological treatments include both transthyretin stabilizers and transthyretin silencers. We'll talk about those briefly. Selection of treatment is really, for TTR, is really dependent upon the phenotype, whether the patient has a cardiac predominant, a neurological phenotype, or a mixed phenotype, and whether the disease is hereditary or sporadic, i.e. does the patient have a genetic cause, the cost of the agents, and obviously, importantly, patient preference in a process of shared decision-making. And there are a whole host of clinical trials that are including novel approaches, including combination of silencing and stabilizing, and methods to potentially degrade or facilitate degradation or removal of amyloid deposits from the heart as the involved organ here. So for those treating patients with AL amyloid and involving the heart, a multisystemic disease, we strongly urge you to not to do this alone. Obviously, you need a multidisciplinary team, and one of your main partners is a hematologist. Hematologists have developed a wealth of plasma cell therapies from oral agents, including IMiDs, most importantly, bortezomib and carfilzomib and Ninlaro agents that are proteasome inhibitors. And as I mentioned, the new kid on the block is daratumumab, or Darlex, which we'll highlight in a minute. And there's an oral agent, venetoclax, which has a high activity in patients who have the T1114 translocation. Obviously, in certain patients, intermediate or high dose melphalan with stem cell transplant remains a therapeutic option. The most exciting data to emerge in the AL amyloidosis space recently is the results of the Andromeda trial. This is a trial in which patients with newly diagnosed AL amyloid received either Cyborg D, that is Cytoxan, bortezomib, and dexamethasone, or Cyborg D plus daratumumab. Again, I mentioned a monoclonal antibody that targets CD38. And the most important notice here was that a hematological complete response, normalization of the light chains, was much greater with the combination of Cyborg D and DARA, with an odds ratio of 5-fold higher chance of getting a CR or complete response with Cyborg D plus DARA than Cyborg D alone. And when you lower the light chains, obviously there was a greater effect on organ responsiveness, which is the other part of the equation, including improvements and normalization of biomarkers with regard to cardiac, renal, and liver involvement. For transthyretin cardiac amyloidosis, we know the biology. Transthyretin is produced by the liver as a tetramer that dissociates into monomers or oligomers, and these deposit in the heart of the nerves, causing the phenotype. And the emerging strategies, again, are TTR silencing or knockdown using antisense or small interfering RNA, maybe in the future CRISPR-based therapy. There's TTR stabilizers, of which tafamidis is the only FDA-approved agent, though diflunisal can be used off-label, and AG10 is in development. And then, as I mentioned, anti-amyloid therapies that are targeting amyloid removal or extraction, which some of which, unfortunately, have not been successful in early phase clinical trials. So for those of us caring for patients with a cardiomyopathy without a significant neuropathy, the clinically available options include tafamidis and diflunisal. Tafamidis, as you know, is approved. There was convincing phase 3 data that the cost could limit access. And diflunisal is a non-steroidal that has TTR stabilizing properties. As an NSAID, it needs to be used cautiously in patients with cardiac amyloidosis, but can be utilized in patients without a recent decompensation with good renal function, who are ideally not on anticoagulants and not on high-dose diuretics. The ATTR ACT trial showed that tafamidis was quite effective at reducing all-cause mortality and hospitalizations, with a number needed to treat of about 7.5 patients over 2.5 years to prevent 1 death. and about 4 patients over 1 year to prevent 1 hospitalization. Additionally, tafamidis was associated with an amelioration of the decline in 6-minute hall walk or functional capacity, and a slowing of the decline in the quality of life of individuals, or the KCCQ. As we noted in the original trial, across 11 pre-specified endpoints, tafamidis was superior to placebo except for 1, and that was the group with New York Heart Class 3 heart failure, who lived a little bit longer, as you can see here, but had an increased risk of cardiovascular hospitalizations. And we attribute that to the idea that patients are living a little bit longer, but with a very advanced phenotype in which small perturbations in diet, medicine adherence, or so forth can lead to acute decompensation, for example, in the setting of an atrial arrhythmia. So the emerging data from the ATTR-ACT trial as shown here highlights that tafamidis is better, as is all amyloid agents, when administered earlier in the course of the illness. That is a much greater relative risk reduction of 64% for New York Heart Class 1 patients than 39% for Class 2, and much less for Class 3. So try to identify your amyloid patients as early as possible before they have significant cardiac dysfunction. Here I highlight the 2 available treatment options that I mentioned. There's a tafamidis and tafamidis free salt. Tafamidis meglumine was the original agent that came as a 20 milligram pill, either used as 20 or 80 milligrams daily. There is really no need for concomitant therapy or monitoring, and these drugs are now approved in the US, Japan, and in Europe. Tafamidis free salt is a formulation of tafamidis that's not equivalent on a milligram to milligram basis. You only need 61 milligrams of tafamidis free salt to equal the blood levels of 80 milligrams of tafamidis meglumine, and it's a much easier to take once daily medicine. Diflunisal, when administered for TTR stabilization, is a dose of 250 milligrams twice daily. And because it's an NSAID, you need to be cautious about complications of bleeding, hypertension, fluid retention, or renal dysfunction. And usually we use a concomitant proton pump inhibitor. There's a huge cost differential, obviously, between tafamidis and diflunisal, which could factor into therapeutic choice. The hypothesis underlying the small interfering RNAs or the antisense drugs that silence TTR are shown here. And as you can see, by reducing the production of the mutant protein, we can reduce the unstable circulating tetramers, prevent deposits in the organ, maybe even stabilize or potentially recover the organs. And as shown here in this particular slide, patisiran, at least one small interfering RNA, had significant effects on a regional strain, as shown in this paper from JAMA Cardiology. In the silencer realm, the clinically available options are patisiran or inotersen. They're both silencers. One is delivered IV, one sub-Q. The doses are noted here. All of these need to have concomitant vitamin A supplementation because you're lowering the protein that carries vitamin A, and so without it, patients can develop complications of vitamin A deficiency. Patisiran, because it's IV and a lipid nanoparticle, has to have IV medicines administered, steroids, H2 blockers, H1 blockers to prevent an allergic reaction. Inotersen is sub-Q, but is associated with significant, or at least a risk of complications related to thrombocytopenia and renal dysfunction. And as a result, by the FDA requires a REMS or monitoring procedure in which platelet counts and renal function are measured continuously. And both agents are quite pricey. We're not stopping there in that we've used the silencers currently for patients who have hereditary disease with a neuropathy. They must have those 2 features. They could have a cardiomyopathy as well, but the question remains, how will patients with a predominant cardiomyopathy without a neuropathy fare with silencers? And there are 3 ongoing large phase 3 clinical trials: Apollo B studying patisiran, CardioTransform studying the Axia Ionis compound, and Helios B studying vutrisiran. And as well, there's a phase 3 clinical trial, Attribute CM, that's evaluating a new stabilizer similar to tafamidis called AG10. So in summary, especially for transthyretin and amyloid, I would point out that in a relatively short period of time, about a decade, We have transitioned from what we all thought was a rare disease, a zebra, so to speak, to one that cardiologists are encountering all the time in clinical practice and recognizing with much greater ease. And that is because we've been able to make the diagnosis in a majority of patients no longer with a biopsy, but with a non-invasive, non-biopsy approach, leveraging scintigraphy. I remind you that scintigraphy must be performed in combination with the assessment of monoclonal proteins to rule out AL amyloid. You shouldn't order a PYP scan without assessing for monoclonal proteins. And again, it's essential when leveraging scintigraphy to not only use planar imaging, but to use SPECT imaging. But the biggest driver of the development of recognition of this disease has been the emergence of effective therapies. And I think all clinicians are going to be in an enviable position, along with their patients, about choosing among emerging and effective therapies in the near future. Thanks again for your time.